Anybody, please? Where did we get to? I don't remember. Hello?
Hello, please. After the treatment with the herbal medications,
So we did not reach here, all these slides. So we got to here.
We were about starting the treatment failure.
Oh, okay. So this was the last.
Yes, please.
For treatment failure.
Yes, please.
Okay. So I don't know. Who is the class captain for today's class? If we can
Please, I am.
start. We spent about almost 15 minutes now. Okay, so can we start?
Yes, please.
All right. So I hope that we can finish with this, and then next week we take another infectious topic. But as we started yesterday, last week rather, we did the introduction, the pathophysiology, one or two things with malaria. Then realized that there are two main types: the uncomplicated one and the complicated one. The most common thing among the two is the presence of the malaria parasite, any of the five. If you are able to detect it in the host, then it confirms that there is malaria. But with the uncomplicated one, it's not as serious as the complicated one. But if you don't detect it early and manage swiftly, then it may progress and present as a complicated one. So we tried managing the uncomplicated one with oral medications, basically the ACTs. You realize that nowadays the strategy is to use multiple first line. There is no single ACT that is recommended. So you use multiple first lines. There is an introduction of a new one, that is artesunate pyrrolizine, that because of limited data is not recommended in pregnancy. In addition to the ACTs in pregnancy, a combination of quinine and clindamycin is also recommended. Then later on realized that currently anti-malarials from this group, provided it contains any of these, is also recommended. But there are some contraindications. We discussed all those ones. Then we got to possibilities of treatment failure. So now, in malaria, just like any other infectious condition, there could be treatment failure. One possible means is recrudescence. Last week, we discussed what recrudescence means, relapse, and reinfection. So now recrudescence again is when you have a load, you kill some and you leave some, then those in there will come back and then harm you. So one of the main mechanisms of treatment failure could be recrudescence. And in recrudescence, the same malaria, the same infection that you are treating will bounce back and harm you. In reinfection is a whole new bite. And that one wouldn't normally, the signs and symptoms wouldn't normally bounce back within 28 days after treating the first episode. But recrudescence, the signs and symptoms will recur within 28 days. So for reinfection, you normally get the signs and symptoms after 28 days of managing the first episode. But in recrudescence, within 28 days, the signs and symptoms will be there. This possibly could be due to several reasons. Some of them include inadequate exposure to the drug. Inadequate exposure to the drug. Remember, this is chemotherapy, and successful treatment depends on reaching SIDA concentrations, that is therapeutic concentrations in the blood. So if issues like suboptimal dosing, you are supposed to take 2120, then you take 1060 of artemether lumefantrine, you are exposing yourself to inadequate amounts. So that suboptimal dosing could result in inadequate amounts. And of course, if you don't hit the therapeutic concentration, it's not going to work. If you are a stubborn patient and you don't adhere to your treatment, poor adherence, take the first dose, repeat the second dose within 8 hours or after 8 hours, then you go and do it 24 hours after the first dose. You are not getting your loading concentration, and of course, it may fail. You may also take the drug and vomit. Normally, the drug will have to disintegrate in the GIT, dissolute before absorption. This may take at least 30 minutes or more. So if you take the drug and within less than 30 minutes you vomit, it's likely that you are going to lose, if not all, a higher amount of the drug. And of course, you are not going to get the adequate plasma concentration needed to kill the parasite. And of course, it is advised that once you take these oral anti-malarials and you take another dose to replace the one that you have vomited. If your drugs are not that quality, you go and take a drug that the percentage content is below. Go in there and then the content is 50%, 10 milligram. This means that you are not going to get the required amount. Then there could also be interactions, either drug-drug interactions, drug-food interactions, or what have you. Drug-drug interactions could be pharmacokinetic or pharmacodynamic. Obviously, pharmacokinetic interactions may interfere with issues like absorption, distribution, metabolism, or elimination of the drug. So if you take any medicine concurrently with this anti-malaria and it inhibits its absorption, it forms complex with the drug in the GIT, it means that your drug is not going to be absorbed. You need the drug in the blood for it to kill the parasite. You need the drug in the liver for it to kill the parasite. Absorption must occur. It is advised that you take fatty meal, for example, when you are taking artemether lumefantrine to enhance absorption. You don't take fatty meal, then it minimizes or reduces absorption. These are all possibilities that can lead to inadequate exposure of the drug to the parasite. And of course, another issue is when you are exposed to a parasite that is already resistant to your anti-malaria agent that you are taking. Obviously, it's not going to work. And this resistance is created by our own self. Take adequate doses you don't take. The parasites develop resistance against the molecule or the molecules. Next time when you spread your parasite to other people or you get it again, we give you these same anti-malarials and the parasites are already resistant to it. And of course, the treatment will fail. So these are all possibilities. Recrudescence as a result of killing some and leaving some, inadequate exposure, numerous causes, And of course, when you are infected with a resistant organism, then you are in trouble. Now, should in case you need to manage this, how do you do? How do you go about it? Once your treatment fails, it means that the signs and symptoms, and possibly if complications will occur, if the condition will progress, then it's going to happen. So how do you manage it? You are done with your full course, whether you complied or adhere or not, the treatment has failed. So what do you do? All right. All right. Sorry. So then, of course, what do? You need to actually prove that after the treatment, it has failed. So how do you prove that it has failed? Of course, you need to still detect the presence of the parasite in the blood. And of course, microscopy will help you to detect. So after you claim that you are done with the treatment and we still detect some of these vegetative forms, then it means that the treatment has failed. If, for example, it could also be in combination or concurrently, or you could have other concomitant conditions that could also present with similar signs and symptoms. And therefore, after finding out the parasite with microscopy, you may also have to look out for other possible causes of the problem. Now, if you have a true treatment failure, which means you have done your part, you adhere to treatment, the doses are okay, on point, your drug is top-notch quality, and still the treatment failed. You did not vomit. Everything was okay. All these issues are not there. Suboptimal dosing, poor adherence, vomiting, all these are negative. Yet the treatment has failed. Then possibly your organism is resistant to the treatment. So won't use the same drug that resulted in the treatment failure. So it means that you have to switch to another combination, another ACT, because the first one, you've done your part, still it has failed. So the strategy is to switch. So if you took, let's say, artemether lumefantrine correctly and it has failed, it means that when you are doing it again, you don't repeat artemether lumefantrine. You take either artesunate amodiaquine or artesunate pioneridine. These are all first lines. Or even you switch to the second line oral agent, dihydroartemisinin piperaquine. You can do that. It is obvious that the first one you started with has failed. And of course, what do? You don't, just by common sense, you don't repeat that same thing. It will fail. So this is for true treatment failure. But in a situation where it is not a true treatment failure, not that you did your part, maybe you vomited and you failed to take another dose to replace the one you vomited, you did not adhere or comply to the therapy, you were taking suboptimal doses, your drug suspected to be of poor quality, then of course you can't implicate the first drug that you took. It was because, or the first molecules. Let's say if you took artesunate amodiaquine and some of these, one is not a true treatment failure, which means your first two molecules or the combination that you took, for example, if you fail to vomit, if you comply now, if you take optimum doses, and if you go for a better brand with top-notch quality, then that same drug could work. So, excuse me to use some examples. If, let's say, for artemether lumefantrine, you took something like the green leaf one, the one that used to be 3 cedis, 5 cedis. Yeah. And maybe it didn't work in Coatem, which is the innovator brand. In that case, then it is not the molecule that has failed. It was due to some of these problems. So you can repeat the treatment with the same combination, but with a different brand that may be of top quality. Or if you vomited, then you can even repeat the same brand. But this time you make sure that whenever you vomit within a period of less than 30 minutes, you will take another dose and for it to replace the one that you've lost. And of course, you make sure that you are going to comply. So of course, you can repeat same ACT. Obviously, to be among those recommended as first line, AEEL, artesunate pyrrolizine. So artesunate amodiaquine, artesunate pyrrolizine, or artemether lumefantrine. If you started with any of them, in the case of failure resulting from any of these vomiting and issues, it's not a true treatment failure, so you can repeat. Or you can still switch to another agent if still you doubt that the organism has been resistant to your first dose. So that is how you manage treatment failure in uncomplicated malaria. As I've been saying, if the treatment failure is as a result of reinfection, then of course you will get the signs and symptoms again, but it will be after 28 days of that the fever and all the other signs and symptoms will come in. In that case, it's a whole new infection, independent of the first one. The first episode is over, and this time you are free to go by the normal recommendations. You can take any of the first line agent, artesunate amodiaquine, artemether lumefantrine, or artesunate pyrrolizine. If for any reason you can't take any of this, then you go to the second line agent, dihydroartemisinin piperaquine. Any question? Last captain.
Please, no question. Unless someone has a question.
All right.
Sir.
Yeah, hello.
Sir, please, can you please go over just the latter part? I had network issues, so I wasn't hearing you.
Yeah, so we are talking about how you manage treatment failure. So the treatment failure, it could be true treatment failure that genuinely you did your part. Your drug was of top quality, you adhere, the prescription too was on point, adequate dosing, everything. You did not vomit, you comply with the treatment, but the treatment failed. In that case, then it is prudent that when you are going again for the second treatment, for a true treatment failure like this one, you don't repeat the same agent. It could even be a case of resistance. So in that case, in the first line agent, you can take the other two that are there. So let's say if the first treatment was with artesunate amodiaquine and you took a very good brand, top quality, the dosing was okay, you complied and everything, then you switch to the remaining to any of them, either artesunate pyrrolizine or artemether lumefantrine, or even the second line agent for uncomplicated malaria, that is dihydroartemisinin piperaquine. But when the treatment failure was not a true one like this, but maybe it was due to a case of vomiting and you failed to replace the dose, you vomited within 30 minutes. That means you did not get adequate absorption of the dose. After 3 days, or the dosing was underdose. Yeah, hello? Hello? Hello?
And please, we couldn't see your screen, but Okay, it's not showing now. Okay, we can see it now. Thank you.
Still, you're not seeing it.
We can see it now. Thank you.
Okay. Okay. So if it is not a truth, we do not have, can take the same agent, even the same brand, because you vomited and you decided not to replace the dose, you did not comply. You yourself, you know. So you can't implicate the drug that is of poor quality that the treatment has failed or whatever. In that case, you can take the same agent. Or if still you doubt, then of course you can switch to another agent to do the treatment. And then we are talking about what if the recurrent issue is a whole new infection, reinfection. If it is reinfection, then of course you are going to get the signs and symptoms and even the presence of the parasite only after 28 days. It can be within 28 days of the first episode. In that case, since it's a whole new infection independent of the earlier one, then you are free to go by the original recommendations. You can choose any of the first line agents. Then it demands that you have a special antigen on your red blood cells called Daffy antigen. It is through these antigens that PVVAX can enter the red cells, multiply, and then burst it, and then establish a case of malaria. Fortunately for us, West Africans, we lack that Daffy antigen, and therefore it is very difficult to isolate PVVAX as the cause of malaria in Ghana. Even if it will happen, then it will be the benign type of malaria, because remember, among the 5 species, we've implicated P. falciparum as the only one that can cause the severe type. But let's look at a situation where you have the infection from either P. ovale or vivax. Remember last week we discussed that it is these 2 agents that will leave some hypnozoids within the liver. And should, in case you treat and you only take an agent that kills the parasite within the blood, then what happens is that because you did not take an agent that could kill those in the liver, these are also called extra erythrocytic agents or extra erythrocytic stage. They can still develop, multiply, and without any new bites from a mosquito and inoculation, those that were left in the liver from P. ovale and P. vivax can multiply and then burst out from the hepatocytes and enter your plasma again and then re-establish the case. This is what we refer to as relapse. So it is very important that as you isolate either ovale or vivax as part of the treatment, you will add an agent that can also clear the hepatic stage so that you don't get the relapse. This reminds me of the assignment I gave that you should go and look out for the classes of anti-malaria agents, and the classes you were to do the 2 types. Classification based on chemical structure, that is chemistry, with at least 2 or 3 examples each. Then classification based on the parts of the life cycle that the drug will attack. Class captain, have you done that?
Not yet, please.
It's been a
Hello, Doc.
week.
Please can you go over that again?
Your assignment was to go and look out for the 2 systems that we use to classify anti-malaria agents. One is based on the chemistry, based on their chemical structure. Anti-malarials can be grouped into about 11 or 12 groups with examples. Then the second one was to look out for the classification based on the parts of the cycle that the anti-malaria will attack, either the exoerythrocytic stage, that is in the liver, or the erythrocytic stage, or the gametocyte stage. They are also classified according to where they act along the life cycle. Because this is a typical example. Primaquine. Primaquine is one of the agents that can kill the exoerythrocytic stage parasites. When the parasites are in the liver, they are also active against the gametocytes. The ACTs, normally the artemisinin, can kill the gametocyte as well as the erythrocytic stage. Anybody here with the chemical classifications? Hello?
Sir, please, what do you say about the Primaquine?
So I said primaquine is one of the agents that can clear the liver stage. I asked you to go and do that. That was last week. Have you done it? Hello?
Hello.
So nobody. I'm surprised.
Please,
How many are,
so for the based on the life cycle, what I got for the sporozoids, I had pyrimethamine proguanil. For gametocytes, I had quinine.
please come again. Start again.
Okay, so based on the life cycle for sporozoids, pyrimethamine proguanil. For gametocytes, quinine, primaquine. For the schizons, amodiaquine, quinine, artemisinin, mefloquine. Yes, that's what I had for the
So the
based on the
liver
life
stage.
cycle.
So the liver stage, which ones did you get?
Okay, for the liver stage, the only one I know is the primaquine.
Primaquine. Okay.
Yes,
So
please.
did you find anything as per the chemical classification?
Yes, please. So for four
So what did you get?
aminoquinolones,
How many classes did you get?
1, 2, 3, 4. 1, 2, 3, 4. Please, 5.
Oh no, 5 is too no. Okay, so you give us your classes and examples.
Okay. For aminoquinolones, we have the 4 aminoquinolones and then 8 aminoquinolones. So 4 aminoquinolone example is amodiaquine, and then 8 aminoquinolone primaquine. Then we have sulfonamides. An example is sulfadoxime. We have 9 amino acridine. Example is mipacrine. And then for other antimalarials, I had antibiotics.
You've not mentioned even the artemisinin, the antibacterials, there are about 12 or so.
Oh,
Hello, Doc.
About 12 to 11. Yeah, hello.
Yes, so with the antihistamines, we have the artesunate amodiaquine. We also have artemethyl lumefantrine as examples. Then with
Wait.
the
The artemisinin, you have what?
we have
Hello?
examples. We have examples like artesunate amodiaquine plus amodiaquine.
About
Then
how
we have
can amodiaquine be classified under artemisinin?
with the dihydroartemisinin.
No, listen. The lady just classified amodiaquine as a 4 aminoquinolone, and you are bringing it under artemisinin. In addition
With the combinations, I was talking of
to artesunate.
combinations of
No. We are
attenuation.
talking about chemical classes. The chemical classes is not about combinations. It's about individual molecules
Yes, please.
classified under different chemical classes.
Yes, please. So,
So if you are talking about artemisinins, mention them. Aminoquinolones, you mention them.
yes, please. Let me take it
Okay, so
again.
let's hear you.
So we have a chemical class that's the tetracycline. We have tetracyclines with examples as tetracycline and doxycycline. Then we also have the amino alcohols,
Mm-hmm.
where we have the halofantrin and lumefantrine.
Mm-hmm.
Then we have the naphthoquinone,
Mm-hmm.
where we have atovaquone as an example.
Mm-hmm.
Then we have the biguanide,
Mm-hmm.
where we have the proguanol and chlorproguanol.
Mm-hmm.
Then we also have
Yeah.
the diaminopyrimidines, where we have pyrimethamine as an example. So, and then the cinchona alkaloids, which we have quinine and quinidine. That's what I was able to find.
So please, can you hear me?
Yes, please.
Okay. So it's okay. So everybody should please go back and then look 11 or 12 and get the execution as part of the agent area.
Hello, Doc. Please, your line is breaking.
For to look at agent that we use for prevention, then doxycycline will come in there. So it means some antibiotics will also have these antiprotozoal effect, notably doxycycline and clindamycin. So note them. So yes, using this classification, that is classification based on where they act along the life cycle. A key agent there is primaquine. And of course, if you are killing those in the blood, if the isolate is Oveli or Vivax or both, then it is important that you also clear the liver stage to prevent relapse. And therefore, the new recommendation is that once either Vivax or Oveli or both, you isolate them, you do the artemisinin-based therapy, any of the first lines or second lines as appropriate, but you also add primaquine to it. This is to help clear the hypnozoites in the liver to prevent relapse. Unfortunately, primaquine is one of those agents when we're doing GCPD-induced anemia. We implicated primaquine as one of the agents that can cause hemolytic anemia as a result of lack of the enzyme called glucosase phosphate dehydrogenase. So the key thing is, before you give your primaquine, in addition to the ACT, you need to find out the GCPD status of the patient. Once it is Oveli or Vivax, then you should be getting ready. But there is an inclusion and exclusion criteria based on GCPD status. Again, primaquine is contraindicated in some category of individual, aside even whether you are defective or not. Aside the GCPD status, certain conditions may not permit you to take primaquine. When somebody is pregnant, primaquine is contraindicated. Infants who are not up to 6 months, please don't do it. Then if a lactating mother, you can't take it, especially when the infant is less than 6 months. Even when you're a lactating mother and your infant, we are not sure about his or her GCPD status because primaquine appear in breast milk in high quantities. So if you don't know the GCPD status of such an infant, it passes through the milk, it gets to the infant, then possibly hemolytic crisis may occur. So in these individuals, aside them being G6PD defect, it is not advised that they take primaquine in addition. And of course, depending on your G6PD status, you will take primaquine. But if you qualify to take it, you may take different doses. So individuals who do not have any G6PD problem, this is the recommended dose. They take 0.5 milligram per their kilogram body weight. That is the primaquine base, not the salt. The salt normally will come with a higher strength. Out of it, then a certain quantity will be the primaquine molecule itself. Then it should be taken for 7 days. Previously, before the 2023 update, the recommendation was for 14 days. But nowadays, they've reduced it to 7 days. Remember, you are taking this in addition to the ACTs to kill the erythrocytic stage. Primaquine is to be added. So for those who don't have any G6PD, this is what they are going to take. Then individuals who have a defect, but it's not full defect, partial. If you have partial defect, and that can only happen in females. When it comes to males, we are either defective or we are free from G6PD. When it comes to females, females could be partially defective, they could be full defects, or they could be normal. Can someone explain this phenomenon? Why is it that in males, you have just two? It is all or none when it comes to G6PD status. It is whether you are what? Defective or you are not. There is nothing like the intermediate. But in females could be defective, normal, or intermediate. Can somebody explain this? G6PD status. I don't know whether we discussed it during the anemia. I don't remember discussing this one during G6PD induced anemia. But the second group, I remember doing this discussion with them. Somebody asked this, then I had to tackle it. Class captain, can you give us explanation as to why females can have or can fall in 3 different classifications in terms of G6PD?
Could you kindly help us?
Okay, so you are.
Yeah, hello. Hello.
Yeah, hello. Yes, sir.
Yeah, so you said the females have two of the X's, whilst the male X and Y. So in the males, because we have only X, it only affects only just one X, and therefore we either have it or we don't have it. But then for the females, because they have two X, it can be that it will just affect just one, or it will be partial, or it will be the both of the X's. It will affect the both. That's why they have 3 kinds. So that is what I remember.
So you mean the problem is an X-linked recessive condition? Is that not so?
Yes, please.
Okay, perfect. So that is the reason. The reason why males can be here or there, just 2. Either you are positive or negative, you are defective or normal. But females can be normal, can be defective, can have partial defect. Because G6PD is an X-linked recessive gene condition, meaning that it affects the X chromosome. Males, we have X and Y. So the moment it affects the only one X that we have, we are done. We are done. So you could be full defective or you will not be affected. So you'll be okay. For females, they have 2 X. So if one is affected, one could be intact, and that will give them the intermediate or partial defect. Should in case one is affected and unfortunately another problem also destroys the other X, that is when they would have that problem. They call it lionization or distraction by another issue. So then the GCSPD will affect one of the eggs, then another issue will affect the other eggs. That is the only way females could have full defect, or none of the eggs will be affected, then they will also be normal. So in females, possibilities 3: normal, partial defect, full defect. In males, because we have just one X, that is XY, if that one is affected, you have full defect. You can't have partial defect, but you can only have full and no defect. Okay, so those who have partial defect, this is their dosage recommendation: 0.75 milligram per their kilogram body weight. Remember, we are talking about the molecule itself, so the base, not the salt. They take it once a week for 8 weeks. Remember, they have partial defect, so there is still some possibility of the reaction. So they are not taking it daily as these individuals, though they are taking a relatively higher dose, but they are taking it just once a week for 8 weeks. So you realize that these people will be taking more because they don't have no defect. Now, should in case you are unable to find out the GCSPD status, then of course you are going to use your clinical judgment. You weigh the benefits of possible hemolysis that will lead to anemia and other complications versus the benefit of clearing the hypnozoids in the liver to prevent the relapse. Even with that, if you are able to say that yes, the benefit outweigh the risk, it should go with a very close monitoring, because anything at all can happen. So this is how you do it. So yes, so this is the confirmation. You can see males, we can only be what? Effective or normal. Females, you see that we have 3 colors for them. Either they are okay, or they are what? Partial, or they are normal. So normal, so that is the enzyme activity. So once you measure the enzymes activity and you hit 80% and above, it means that you don't have any problem. So it is the enzymes activity that they measure, and at times they relate it to concentration. So 80% activity means that yes, you don't have any defect. If you have between 80 to 30%, then there is partial defect. Anything below 30%, it means that you have a problem. So you can see that males, it is either you don't have any problem, 80%, or worse, around 10% or less. Females can have between 0 to 30%, between 30 to 80%, so they are partial, or they could also be okay, as we have discussed. And previously, as I said, the dose for these individuals, those who don't have any defect, was for 14 days. Now, as part of the new recommendation, so the current one, so this is a very good exam question. The duration of treatment for Primaquine, as per the current recommendations, then they will bring 7 days, they will bring the 14 days, 1 month. They've changed it to 7 days now. So note, it is no more 14 days, but rather 7 days. The contraindications in 6 months, when breastfeeding for women breastfeeding 6 months, all the contraindications are still here. If not, you add it to prevent relapse. Any question? Any question? Class captain.
Please, no question.
If not, okay, so then we are done with uncomplicated malaria. So quickly, okay.
Hello. Yes. So I
Yes,
saw
hello.
something about the WHO recommendation of giving treatment of Primaquine after ACT therapy to target the gametocytes for their eradication of malaria program or something.
Mm-hmm.
So they said irrespective of
Hello?
GCSP, those in deficient individuals. Hello. Hello.
Hello? Uh-huh. I'm listening.
Hello, Doc. Can you hear me? Hello.
Yes, better now. Yeah, I can hear you now.
Yes. Yeah, so I wanted to ask about the WHO
Your line keep up.
recommendation for giving.
So that recommendation is about one of the newer ones that they are targeting. With that one, it is a measurement. It's very low, very, very low, different from this one. I'm trying to get to that slide. And then, so it came up and they have the plan of rolling that one out from this year, 2024. So in that case, you give a very low dose. I don't know whether it's this one. Yes. So we'll get there. So when you want to prevent transmissions in low transmission areas, so that is that recommendation. So when they say low transmission areas, they are referring to areas where you have just 1 to 10% of the whole infections being covered by Plasmodium falciparum parasite. Or when you have per 1,000 people, 100 to 250 are getting the infection, and the infection, that 100 to 250 is by P. falciparum. So in that case, you do this. So you target the gametocyte so that the mosquito will not come and take the blood meal and then pick them and go and spread. So you take a very low dose just once. You see the 0.25 milligram per kilogram body weight. The maximum that we give to them is 15 milligram. And that one, it won't affect the GCSPD status. So that is one of the newer recommendations that they plan rolling it out this year. We are already in the 4th month. I don't know whether it's out or not. So we will come back to this. Are you okay?
Yes, please. Thank you.
All right, welcome. So any other question? Any other question? If not, class captain, let's start with severe malaria. We are done with uncomplicated malaria. So severe malaria, as the name suggests, is severe. Over here, we are talking about falciparum, not any other parasite species. No, P. falciparum, because it is only falciparum that has the virulence to be able to cause severe malaria. Example being cerebral malaria, which commonly is very common in infants and other children. So what happens is that P. falciparum, when it invades your red blood cells, it has the virulence to modify the surface of the red cell membrane. And normally, when they go in there, the red cell membrane is able to express some proteins. So and these proteins are adhesive in nature. They are sticky. So these proteins can stick to receptors on appropriate sites. So, for example, these proteins can even stick to the walls of the blood vessels. Once they find their receptors there, they can even stick to the cell membrane of other red cells, platelets, and what have you. So this makes it possible for the red cells to clump together, form some kind of a clot, and block blood vessels. If they also stick to the walls of the blood vessels, they can also narrow or block the blood vessel altogether. And this reduces the supply of blood to areas that are distal to the point of blockade. Then you have a problem. So when the red cells are invaded with this P. falciparum and the proteins are expressed, you could have red cells containing the parasite, that is parasitized red cells. We are talking about P. falciparum. Because of the expression of these sticky proteins, it will make these red cells stick to other red cells, because you could have other red cells, though not infected, but the newly expressed proteins on the surface of the one that's infected may have its receptor on the one that is even yet to be infected. Or it can also stick to other red cells that has been infected. So the red cells will form clusters, otherwise known as rosettes. And this just looks like a clot. As I said, it can block micro blood vessels. Apart from this, you can also have the parasites within that red cells with the sticky proteins also sticking to the walls of the blood vessels. If this happens, then we refer to it as cytoadhesions. So red cells sticking to other red cells is clusters or rosette formation. Parasitized red cells with these sticky proteins expressed on their surface, sticking to the walls of blood vessels, is termed as cytoadhesion. And be it rosette or cytoadhesion, you could have blockade of blood vessels, especially the small blood vessels, which obviously will block them and minimize blood flow. If this happens in children, especially, and it minimizes the flow of blood to the brain, that is what results in cerebral malaria that comes with high fever and convulsions. So now, what are some of these proteins that will be expressed on the membrane of these infected red blood cells? So these proteins are together called the parasite-derived variant surface antigens. Those without the parasite will not express these proteins. Those with the parasite will express these proteins. First one that is normally developed, the very first protein that is normally developed on P. falciparum infected red blood cells is called the P. falciparum erythrocyte membrane protein 1. That is the first protein that is expressed, followed by the repetitive interspersed family proteins that normally is expressed after the first one. Then the one that normally comes last is the subtelomeric variable open reading frame proteins. That is also expressed as the last one. So interestingly, you can see these proteins here. These are the proteins that are expressed on the surface of the red cell. So STEVO stands for the second one, the third one. Then you have REFIN for the second one. Then P. falciparum membrane proteins is here. So these are the receptors for each of them. So for example, you could have complement receptor 1 as the receptor for these receptors on, for example, red blood cells. So it means that when this ligand is expressed on infected red blood cells, even normal red cells without the infection, because they have this receptor on them and the ligand has affinity for this receptor, it means the infected red cell with this protein can stick to this red cell by hooking onto this receptor. You can see chondroitin sulfase also as one of the receptors, and it could be found on endothelial cells. So the endothelial lining of the red cells could have these chondroitin sulfate, and it is one of the receptors for this protein. So meaning through this receptor, cytoadhesion can occur. A red cell that has been infected with P. falciparum with this protein expressed on the surface can easily stick to the walls of the red blood cells by hooking onto chondroitin sulfase. Agents or receptors like heparin sulfate This is ubiquitous. Almost every tissue will have it. And therefore, it includes the walls of the red blood cell, the blood vessel. PFEMP1 can stick to it and then cause cytoadhesions. You have vascular cell adhesion, molecule 1 as one of those receptors. This is very common when it comes to the endothelial cells of the blood vessel. It can hook onto it. So this is how it happens. It's not just they go and then stick. They have specific receptors that are found on special areas, special tissues, be it red cells, blood vessels, and the moment this express protein encounter any of these receptors on the site, they hook. That could result in rosette formation or cytoadhesion. The final effect is possible blockade of that blood vessel, minimizing or preventing blood supply to all other areas after the point of blockade. Your guess is as good as mine. Anaerobic respiration will ensue, excessive lactate formation, eventual tissue death as a result of inflammation. TNF alpha will be released, so tumor necrosis factor, and therefore there will be necrosis. We are in danger. This is how disease of severe malaria. Any question? Any question? So this is
Call somebody.
site membrane protein 1 sticking to some of receptors. So ICAM, heparin sulfate, whatever. So you have some of them. You can see the parasitized red cells now sticking to the walls of the blood vessel. The endothelial cells, they are sticking to it. Over here, you can see cytoadhesion plus within the middle rosette formation. So you are getting blockade of this blood vessel, and all the areas after us, there will be trouble. As I said, anaerobic respiration will ensue, eventual inflammation will occur, inflammatory mediators like tumor necrosis factor, leukotrienes, and what have you will come in, and destruction of the tissues will happen. These are more further examples. So infected red blood cells will now stick to the endothelial lining, being referred to as cytoadherence. Infected red cells sticking to other infected red cells, or infected red cells sticking to even non-infected red cells. So red cells sticking to red cells, whether infected or not, that is rosette formation. And this is what normally happens. Cerebral malaria, reduced blood supply to the brain tissue. Metabolic acidosis will ensue. You have a lot of lactic acid being produced from the possible hypoxia, and therefore you are in trouble. These are all further illustrations, which means almost the same as we have discussed. So that is the cause of our problems. Any questions? So that is the pathophysiology. All right.
Sir, please, can this also lead to splenic sequestration?
Yes, because once you have some of the receptors within the spleen, let me check if there is, yeah, you see this is all tissues. So including the spleen, you could have heparin sulfate, then this can stick there. But in the spleen, when it gets there, there will be distraction as well. So if more and more come there, that is when the spleen will even overwork and then become larger than normal. So you could even have splenomegaly when it comes to severe or complicated malaria. So splenic sequestration can occur because ubiquitous receptors like heparin sulfate will be there and it can cause problems. Any other question?
Okay, thank you.
You
So
can
I was
see
asking
even
because
placenta. Can you see placenta? So in pregnancy, this can even be dangerous. So high hyaluronic acid is another receptor. So it means that within the placenta, you could have another problem there. And placenta is the main route of nutrient and whatever transfer to the fetus. So if you have sequestration there that can block it, then you are in trouble. Okay, you're about to say something.
yes, I was saying I was asking because there was a patient on the ward who previously was showing like certain signs linked to malaria. So they treated the patient first for uncomplicated malaria, but the signs and symptoms did not resolve before the patient was transferred to where I am. And at that point, the doctors were still trying to figure out what exactly was wrong with the patients, even though they said they were hemoglobinopathies, but they couldn't get the exact cause as at then. So I was thinking if this could be a reason to, and the patients had an enlarged spleen.
Yeah.
So they were
So
wondering what's like.
was there any sign of complicated malaria?
At that point he had anemia, so he was transfused with blood, even though he was much more stable. But then the
Even
main thing
that
they were
alone,
wondering,
you see,
pardon?
so that was a mistake. The fact means that that was severe anemia. So in malaria with even only severe anemia, why did you guys decided to treat it as uncomplicated?
So we're the ones who treated it. So per the history, the facility he was coming from, they had treated that.
Okay, so when it came to you, what did you do?
So when it came to our end, what some of the diagnoses we're looking at was hemoglobinopathies. Like they weren't getting the exact thing, but you explaining this, I was just wondering if, based on the history that was given, it could rather be related to this or not.
But did you confirm the presence of the parasite at your end?
I don't remember if that was done or not.
So once you have signs and symptoms of complicated malaria and you realize that they did not treat it as such, but they use the uncomplicated means, then obviously that can't work. So it means that you had to confirm still the presence of the parasite and manage it as such. Manage it as such by switching or repeating the treatment by using injectables, preferably the IV artemisonate. Because that is the only way out. If you don't confirm the presence of the parasite and then clear it by using the very, very effective agents, without using orals nowadays, at least for the first 24 hours, then somebody treated malaria, they tackled it as uncomplicated. It came to you, you realize that at least there is severe anemia, which is one of the problems in rather complicated malaria. So the first move is confirm the presence of the parasites. That once it was complicated and they treated it as uncomplicated, it is highly possible that you could still have the parasite in there. So the main strategy is to repeat the treatment, but this time you manage it as complicated malaria with the supportive therapy as the hemotransfusion and the others.
Yes, sir. Thank you.
Why this of complicated? You switch to the recommendations for the management of complicated. Anyway, all right. So any other issue? So splenic sequestration is just one of the problems, as severe anemia and the others. But all in all, the most important strategy, apart from the supportive care, is to eradicate the parasite. You clear all with IV artemisinin, which is now preferably IV artesunate. At least the first 24 hours, you take your first 3 shots. Then you assess the patient and decide whether to switch to the oral ones or to continue. It depends on the improvement. All right, class captain, any other issue before we continue?
No.
All right, so now let's uncomplicated one. We were talking about the normal chills, bitterness in the mouth, moderate to, let's say, at times high fever, just the normal things, loss of appetite, malaise, and what have you. If you come to complicated, as the name suggests, severe malaise like fever, it will be the very, very high one called hyperparexia in the regions of 38 getting to 40, 39, 38.56, 39 to 40. You are cooking. You are going to get to boiling point. Then, of course, there could also be vital organ dysfunction, which is typical of complicated malaria. So let's look at the signs and symptoms that normally happens. You'll see that now the patient, especially if it's a child, will not even be able to drink nor eat anything. Whatever that you give will come out. So vomiting everything that he or she takes. Of course, because of the cytoadhesion or rosette formation within the blood vessels that supplies the brain, there could be the presence of CNS issues like convulsions. Of course, since it is severe malaria, no appetite, vomiting, losing a lot of fluids, electrolytes, the person will be lethargic and becomes very weak. Worst case scenario, the person could progress to an unconscious state. How about vital organs? Let's look at it from the angle of vital organs. So in the CNS, as you said already, convulsion, lethargy, then the person becomes confused, then convulsions and loss of consciousness will occur. In the lungs, you could also have these rosette formations or cytoadhesions happening within the blood vessels in the lungs. When it blocks, remember that you are going to get problems. So the person will have it difficult to breathe. And of course, there will be respiratory issues. This can also result in respiratory acidosis because you are not able to breathe in and out well. You retain carbon dioxide, you don't bring in oxygen. Heart issues. The person could go into shock. Excessive inflammation that happens could lead to excessive release of inflammatory mediators, including can lower the BP. The person will therefore present.
Dr. Jema, please, your line is breaking. We didn't hear what you just said.
And got it. I decided not to take any medicine. Nobody was. Yeah. Oh, okay. So, did you hear about the lung issue?
Yes, please.
Okay. So, the heart. You realize that because of the hypoxemia and the subsequent hypoxia, the person is going to have acidosis with a lot of inflammatory attacks. As part of the inflammatory attack, the person will release inflammatory mediators that can cause vasodilatation. Example being histamine. This vasodilatation can lower the BP and result in shock. Key markers include cold extremities. You feel the person's fingers and toes and they are very cold, meaning that you can't get enough pump to move the blood that supplies temperature across the body to the extremities. So it means you are dying. And I was saying that it has happened to me before. You realize that your fingers and everything, they are becoming stiff, well straightened, and when you yourself, you touch it, you realize that they are very cold. So it means you've started the journey. You are about to die. You could have issues with the liver if the liver suffered from getting enough blood supply as a result of blockade, then of course it cannot do its work of storing excess glucose as glycogen and then converting it back to glucose when it is needed in between meals. Gluconeogenesis in the liver too cannot occur, so the person will normally suffer from hypoglycemia. This can give you CNS problems. It can kill you. The liver is supposed to conjugate bilirubin for excretion. Once the liver becomes defective, then yellowish discoloration of the sclera and the palm, that is jaundice. You could have kidney issues. Excessive breakdown of the red blood cells can present a lot of hemoglobin to the kidneys. This is either converted to hemosiderin for excretion, or it can even precipitate in the kidneys and destroy the kidneys. Hypoperfusion to the kidneys as a result of rosette formation or cytoadhesion can also destroy the kidneys. Even you vomiting, you are losing a lot of water, you are not having enough taste, no appetite, so you are not drinking, you are vomiting, plus high body temperature, you are losing a lot of fluids. This again will contribute to hypoperfusion. All these can result in kidney failure. The key marker will be a decreased GFR that will result in a decreased urine output. Typically, for example, as per the KDIGO guidelines, if you have urine output less than 0.5 mils per your kilogram body weight per hour for at least 6 hours, then that is described as AKI. You're having an acute kidney damage. So malaria can lead to that. The presence of hemoglobin and hemosiderin in the urine, that is hemosideриnuria and hemoglobinuria, will give you the typical Coca-Cola-like urine, a very dark-colored urine as a result of excessive hemolysis from the parasite. When it comes to blood issues, obviously, you may suffer from severe anemia. In fact, your clotting mechanisms could all be affected. Your liver is sick. You could have problems with platelets, and therefore there could be issues with disseminated intravascular coagulation. You could bleed abnormally without any possible reason. Then in general terms, of course, severe dehydration from vomiting and excessive fever and you not taking anything. Typical marker will be the sunken eye. So you go and see this person, you see that this guy is not well. You can see this huge hole under the eyes. The temperature will be very high. That is hyperparesia. Excessive inflammation that leads to shock may cause a shift from high body temperature to hypothermia. So if you have inflammatory attacks, it is either you get high temperature or you get a very low temperature. Below 36 degrees Celsius, you could get hypothermia or you could get hyperthermia. And of course, once you are weak and you can't do anything, there will be prostration. General weakness will be there. So these are typical of severe stroke complicated malaria. It means we are not joking because any of this can lead you to your grave. So we don't have the time to play around. Even in uncomplicated malaria, we are saying swift detection with prompt treatment. How much more the higher one that comes with these vital organ dysfunctions. And it means that P. falciparum is dangerous. You may play with the others because, hello?
Dr. Jaman, please, your line was breaking. Could you kindly come again with the last statement?
The general problems, right? You heard about the hematological.
Yes, please.
Okay, so the general ones, I said the patient will not be eating, you are not drinking, you've lost appetite. Even the one that goes in there, you are vomiting. You have this high body temperature, you are losing insensible. Through insensible heat, you are losing a lot of water. And of course, the person will be what? Dehydrated. So sunken eyes, loss of skin turgor, and dry mouth, dry membranes, all these are there to confirm that indeed the patient is severely dehydrated. Of course, once you have weakness and those things, you will suffer from prostration. You can't do anything. Generally, you are weak. And again, I'm saying that, yes, typical of severe malaria, it comes with hyperparexia. But if the inflammatory response becomes excessive, then it could also shift from high body temperature to hypothermia. That is when the systemic inflammatory attack becomes excessive and you are overwhelmed. So the body temperature could even drop to below 36, and that also shows that you are going. So meaning severe malaria is no joke, and when it's diagnosed, prompt treatment is the way forward. Coupled with okay, so based on these vital organ dysfunctions, hematological, heart, what have you, these are normally some of the lab findings in severe malaria. So we are saying that if you get anemia, it will not be the mild type. The mild type will happen in uncomplicated. So in severe malaria, we are expecting severe type of anemia. So when do we say that in malaria we have severe anemia? In pediatrics, when the HB drops below 5 grams per deciliter, and in adults, when it drops below 7 grams per deciliter. We said hypoglycemia could occur. What are some of the possible causes? We've said that you are not eating, you are vomiting anything that you eat. You may have liver issues that you can't do glycogenolysis, you can't do gluconeogenesis. The sad thing is that even the parasites will also feed on the small amount of glucose that you have in your plasma. So that will further decrease your plasma glucose. Another possible issue is, should in case you use an agent for the treatment and it is a secretagogue, that can cause the release of insulin. Typical example is quinine. Quinine is a secretagogue, so that one too can cause insulin release, which will further reduce your plasma glucose. So possibly about 4 main issues with hypoglycemia. The patient can't eat, vomiting anything that enters the GIT. The liver could be what? Dysfunctional, and therefore gluconeogenesis and glycogenolysis can't take place. The third one is the parasites. Since you have high parasite load, they'll be feeding on your glucose as well. That decreases your plasma glucose. And then the last possibility is that the drug that you may use in the management, it may also have a secretagogue effect. That is, it can cause the release of insulin. Typical example is quinine. This will further decrease your plasma glucose. So we say that somebody has hypoglycemia when it drops below 3 millimole per liter. You multiply this by 18, then you get milligram per deciliter. Renal impairment, we've discussed it, hypoperfusion due to maybe blockade, rosette formation, cytoadhesion, or even dehydration. All these can cause. Markers include the metabolic waste product that the renals are supposed to excrete or build up in the plasma. So you have high serum creatinine and urea, then possibly urine output when it is lower than 0.5 mils per kilogram body weight per hour for at least 6 hours. Of course, jaundice, liver issues, and possibly even if the liver is not affected, excessive hemolysis by the heart, hyperparasitemia. So you have a lot of parasites destroying excessive amount of red blood cells. You are going to release excessive bilirubin. that even if the liver is not affected, because you are sending a lot of hemoglobin there with a lot of bilirubin, you overwhelms the liver's capacity to conjugate and excrete. And therefore, plasma or serum bilirubin concentrations above 50 micromole per liter is normally common in severe malaria. Metabolic acidosis as a result of hypoxemia and hypoxia in tissues beyond the point of blockade by rosette formation or cytoadhesion. So your body will try to use bicarbonate to neutralize the excessive lactic acid that is being present as lactate concentration increases. As you are using your
Sorry,
bicarbonate to
Dr.
fight the
Bobo.
acidosis,
Sorry, Dr.
the
Joseph.
bicarbonate concentration.
Please, your line was cutting. So your explanation for the metabolic acidosis, I couldn't get the total thing. So please, could you go over? Thank you.
Okay. So for metabolic acidosis, remember we said there could be hypoxemia because you would get either cytoadhesion or rosette formation that prevents blood supply to certain tissues. So all these tissues will be undergoing anaerobic respiration. Then you get a lot of lactic acid production. That will increase your lactate concentrations to regions higher than 5 millimole per liter. When this happens, naturally, your body will use your natural acid buffer, that is bicarbonate, to try and neutralize the acid. By so doing, your bicarbonate concentration will drop. So when you see bicarbonate concentrations typical of below 15 millimole per liter, which obviously will go with increased lactate concentrations, this means that metabolic acidosis is in there. So the metabolic acidosis obviously goes with high lactate concentrations, but decreased concentrations of the natural buffer, bicarbonate. Of course, the Coca-Cola likes urine, hemoglobinuria plus hemosiderin will also happen. This signifies excessive breakdown of red blood cells by the high loads of P. falciparum, hyperparasitemia. We have different cutoff points for those who live in areas where we have malaria. We have some partial immunity, and therefore normally it will have to take as high as 500,000 parasites per microliter of blood before normally we get the severe type of malaria. For those who don't have this partial immunity because they are bogus, they are in areas where malaria is not available. Once they come here, they get some small bite and the parasite load hits just above 100,000 parasites per microliter of plasma. Since they don't have the partial immunity, they are vulnerable. They easily develop this type of malaria, severe. But mind you, even those who have partial immunity, you could have a very low parasitemia, yet there could be these signs and symptoms of severe malaria, meaning it is not always that the person will get hyperparasitemia before the problems of severe malaria setting. There could be far, far lower levels, let's say for immune individuals around 200 or even 100,000, yet the parasite will be virulent enough to cause the problem. And also in these non-immune individuals, somewhere around 50,000, they could still develop it. So once you detect very low parasite count, don't say that, oh, then there is still in severe malaria. So do not let the parasite count deceive you. It is just one of the markers. It could be there or may not be there. And of course, we said the person could suffer from pulmonary congestions. Should the blockade happens there, you manage accordingly. Any questions? So you don't wait to see all this. Even the presence of one or more is an indication of severe malaria. once you also confirm the presence of the parasite. And of course, if it is P. falciparum, even one is enough for you to confirm the presence of severe malaria, together with the signs. Question. Class captain.
Please, no question.
Okay. So yes, that is what they are saying. Do not delay treatment because you want to go and confirm these problems. Because you want to confirm the presence of all these, then you are delaying. No. Once you see the signs and symptoms, immediately you may have to start. Note that even in severe malaria that we expect hyperparasitemia, you may do your RDT, it may fail. In severe malaria that we expect hyperparasitemia, you may do your RDT and it may be what? Negative. But if the clinical presentation per your experience is consistent with malaria, then of course, don't end it there. You may have to repeat the test again at 12 hours time and even do a third test, even if the second one still gives you negative. You may have to do it. And at times it happens. At times I've seen a case where the thing was positive after the 6th test. All the first 5 tests were negative. But the 6th test, it was positive. But in this case, as you do 1, 2, 3 tests and it's negative, it could also be AIDS may be another condition altogether. And therefore, at the same time, you should be trying to do differential diagnosis to find out if there are other possible causes other than malaria. So issues like UTIs, ear infections, typhoid fever, and the likes, those that can present. You may also be doing all those tests at the same time. But the key thing is, please, we do this a lot. We do just one test, especially at the community pharmacy. Then we say it's negative, so I won't treat any malaria. We do it a lot. So this is to let you know that even in severe malaria that we expect hyperparasitemia, the test could still be negative. If it happens, the policy recommends that you repeat the test 12 hours time. If that one even fails and you still have strong clinical suspicion that malaria is there, you can even repeat it 12 hours again after the second one. Any queries? So just that your one-time test and you conclude that it is negative, so go away. Please, you are killing people. You let somebody's uncomplicated malaria progress to become complicated, which could cause a lot of problems. Any question? Any question? Past captain, can we continue?
Yes, please.
Hello. All right. So now, if you want to manage severe malaria, what are then our targets? Of course, this can kill the patient. We don't want anybody to die, so we would want to prevent the patient from dying by managing complications. If there will be any disabilities, for example, if there are CNS abnormalities, specific organ damages that can lead to disabilities, we don't want that one to happen. And since you have hyperparasitemia, it is possible that we may kill and leave some behind to cause recrudescence or even non-optimal exposure of the parasite to the anti-malaria agent. We don't want to cause recrudescence. We don't want to cause resistant strains. So these are very important. So how do you manage it? Obviously, you may have to kill. No, you will have to kill all the parasites. You will have to kill all the parasites. In severe malaria, the person may need resuscitation. So the person's hemodynamics may be wrong, BP rising or crashing, Fluid status very bad, that is fluid balance, input and output not matching, all these issues, CNS abnormalities. So the person may need resuscitation and other supportive therapy like managing the fever and the rest. Of course, afterwards you need counseling. Why do you sit there for malaria to move up to complicated malaria? Why do you even sit there to get the malaria in the first case? We have several preventive measures that you can take to prevent the onset of uncomplicated for it to even graduate to complicated. Afterwards, you need to follow up the patient. If you are in a facility where you can't manage complicated malaria, then referral is another very good service that you can offer. Service is not always about you doing the treatment. Referral too is one of the services that you can offer. Because if you don't have the means to manage and you try to admit and manage, you worsen things. So if you think you can manage based on the presenting condition or status of the patient, just provide referral service to the appropriate clinic that can manage the situation. With severe malaria. So all patients with severe malaria, there is nothing like community pharmacy treatment or cheap compound treatment. Once you realize that your level of care has it that you cannot give parenteral anti-malarials and especially IVs, please refer. Because severe malaria is inpatient care. We don't do severe malaria at OPD basis. And of course, when the patient is admitted, as I said earlier, whether you like it or not, your first 24 hours, we are going to give you injections. That one is compulsory by force because we want to what? Minimize the parasite load as high as possible. Please excuse me, just 1 minute. I'm coming. 1 minute. Oh. Bye. Hello? Hello?
Hello.
Yeah. So now, for the first 24 hours, regardless of the type of agent that we use, you are going to take injections, at least for the first 24 hours. And then looking at the progress, should in case the patient gets better and maybe now can tolerate oral medications with improved clinical parameters, then we may switch to the normally recommended ACTs for uncomplicated malaria. If the patient fails to improve, then we will continue with the injectables, and depending on the agent, we may do either 5 days or 7 days. All things being equal, this is the hierarchy of recommendations. In complicated malaria, IV artesunate is number 1. That is first line. If for any reason we